Okay. Okay. Well, today we have chest trauma. It is posted, and I did open up some more modules in operations, and I opened up some more modules in this course, 1501. So we're on track. I'm looking at things. We're in really good shape. So good shape that we may actually be able to lecture a little bit in the operations, just kind of get some things knocked out there.
I know.
What are you talking about?
You're like, oh, we're gonna have to take it again.
You don't have faith that we faced it.
I posted the scores, and I thought they looked okay.
Yeah.
We're going to retake all the tests.
What you were saying yesterday would be like,
So you said don't make sure to come back.
Yeah, I want you back here.
Say this guy.
Wait, what do you mean we're gonna retake all the
Yeah.
tests? Sound very confident.
We'll retake all the tests, not out of punishment, but we'll review them and retake them.
Would you consider that a pretty hard test? Or no?
Yes. Yeah, I know what the cut score is on it. The cut score is 62.
just above me.
That's a pretty hard test. Pretty hard test. Okay.
There's
So-
a lot of somatic and visceral questions that I just didn't really pay attention to.
We'll go over all of them, and when you see the statistics, that's how we'll review them. I'll pick out the ones that statistically I have to talk about. So it's this somatic and visceral.
Somatic and visceral.
Hey, Jonah, let me fix that for you. All of you, I can fix that real quick. That visceral somatic stuff. Have you ever had a visceral feeling, or you ever heard the term a visceral feeling?
No.
Y'all have got to start reading. you guys have to start communicating and having conversations with complete sentences. Use all the characters. There's 26 letters in the alphabet. Use them. Don't abbreviate. You know what I'm getting at. Write a letter. Read a book.
Learn something every day. That's what you're saying.
You learn something. Well, yeah. I've done this a long time now, and I promise you, and I'm not just saying this, as the generations go by and the years go by, those what used to be common English words and used in everyday speech aren't anymore, but they have such a basis in everything that we talk about. When I say I have a visceral feeling, I have a gut feeling that something's about to happen. That feels real. That feels visceral. It's a gut feeling. Where is it? But where is it?
inside.
It's just in here, isn't it? But if I have a somatic feeling, specific. I can point to it, pinpoint it.
Because there's also talking about, like, do you feel the pain, like, inside the organ or on the outside of it? Because there's some interesting questions.
It's talking about where the nervous layer is. So we'll just play with trauma a little bit. When we get bleeding in the abdomen, the organs don't feel it. And maybe I can say this and it'll help you remember it. There are people, because of their religious culture and beliefs, will get a colonoscopy without sedation. Yeah, right? I mean, I was so happy for sedation when I had my one and only colonoscopy. I'm like, yeah, give it to me. Let's go. Because I was looking at the wall. I'm like, that's going in me? Oh, wow. Oh, wow. They hang it on the wall for you so you can see it. And the camera's on and you can see the floor. And then they give you a picture of it. Well, when they go in and they cut out the polyps or whatever they have to cut out and do, these people who do it with no sedation, they don't feel it because the organs don't have nerves. When you get abdominal pain, the pain you feel is not from the organ, it is from the blood irritating the peritoneum. That's where the nerve endings are, in that sac that holds the gut. Does that make sense? And that's what makes it rigid, what makes your tummy hurt and things like that. Or you probably had a tummy ache due to some distension or some trapped gas or something, and it's because that organ is going out, bulging out. Not because the organ's bulging, but the bulging organ is touching the sac. And that's why you feel that pain.
What about hollow organs? We asked a question about that. What is that pain called?
I'd have to look at the question more specifically. And what you're off into there, what we're off into there when we talk about that stuff, what are we going to do with it? You know, what are we going to do with it? So while it's kind of a nice to know thing, and it's in the textbooks obviously, but what are we going to do with it? And then when you go up to the registry, if you can't do anything with it, they're not going to ask you about it. So that's a pretty good way to hone yourself down for the registry. It's like, how's this going to apply to me in the field? There's a whole lot of that today in today's lecture. There is a lot of stuff in chest trauma, but what do I do with it as an EMT? Go to the trauma center. What do I do with it as a paramedic? Of all this, there's only really one or two that I can do anything with as a paramedic. The rest of it is still like you. Go to the trauma center for a thoracic surgeon. Before we dive off into that, we're going to do our civic duties tomorrow, our volunteer spirit, our serving the fellow mankind. I do this every year. Students enjoy it. It looks good for the program. Gives you a feel-good feeling afterwards. But we're going to help them distribute food tomorrow, and the food distribution is done monthly here at the college, and I always enjoy seeing you guys do it and participating in that. So we're going to do that tomorrow. The problem is it kicks off at 8:15, so I need a couple of you here, 3 or 4 of you here at 8. Is that a possibility?
Yeah.
So I can count on you?
Yes.
So if you can get here, if you can't, we're going to rotate through shifts anyway. So we won't all be there at the same time anyway. There are people, some of us box it up, some of them just grab the boxes and hand it to the car. Some of us are at the car, and there will be a sticker on there that says how many boxes they need and stuff like that. So it's a good day. It's outside. It looks good all the way around, and besides, it should make you feel good to do it. Now, don't be mad if people pull up in Escalades getting boxes of food. That happens, okay? So don't say anything about that out there tomorrow.
Could be for their family.
It could be. You never know. It could be somebody picking up for some elderly people somewhere else that don't have a car. So please be PC when it comes to that kind of stuff. Can't judge, right? Can't judge. What else? So 8 tomorrow, and if you would, please wear your uniform, because they like to know that EMTs, we need to start out on the right foot and make the public aware that you guys are good guys, not bad guys. Every good PR stunt is better than, it only takes one bad one, right, to outweigh like a dozen good ones. So, and them little old ladies will go, those EMTs were so nice to me. And that Gus was such a cute little boy. I could just pinch his little rosy cheeks. Gus is like, all right, that's enough.
Can we just wear those t-shirts instead of the zip up?
Yeah. You can wear the t-shirts instead of the zip up ones. If you wear what? Jeans? Yeah. Just as long as you look like you belong to something besides a gang. Frank, how are you this morning?
Doing good.
You doing good? Amber's good? Recovering?
Yeah.
Okay. Billy's back, so we're in good shape. All right, let's dive off into chest trauma. How do I start this? Why does it kill 1.2 million people? Or why does it cause that many visits? Why is it such a bad thing? Yeah, just look at the anatomy of it, right? It's wrapped in ribs for a reason. Everything that's vital to your survival is locked up in either the brain in the cranial vault or in the what we call the thoracic cavity. Can you use that term for me now? Thoracic cavity. Appendages, obviously you can live without those. Can you die from an injury to an appendage? Absolutely. Can you control an injury in an appendage? Mm-hmm. We either tourniquet or splint, don't we? We can get by. What happens in the thoracic cavity? A lot of bad, and what can I do about it?
Not a lot.
Not a whole lot. Not a whole lot. So that's why it's such a bad concept to have chest trauma. Does today's civil society, I hate to say promote, but does it create a society that would make chest trauma more relevant or more frequent? Maybe that's the word. How? Car wrecks would be the biggest one. Not wearing seat belts or the seat belt themselves. Gunshot wounds. Luke, I mean, when you're in, when someone is trained to take out an adversary with a firearm, what do we aim for? Center of mass, right? And that's the chest. Bulletproof armor or protective armor, what does it cover? The chest. So, yeah, we kind of do have a society that's set up for that. We travel fast. We travel at high speeds. We play competitive sports. Damar Hamlin. I'm thinking the wrong guy. You know, took a blow to the chest, commotio cordis, went into cardiac arrest just playing football. So it is a very common injury. Part two, or the caveat, or the catch. Compared to an appendage, how hard is it to find an injury in the chest? Compared to an injury to an appendage, arm, legs, how hard is it to find a chest injury? How do you go about finding a chest injury? Let's just run through a list. Okay, give me the word for that, please. Auscultate. What are you auscultating for? Lung sounds? Anything else? Heart sounds? Anything else? Guts? Who said that? Guts?
Stomach. Gut sounds.
You're auscultating the chest for gut sounds.
Oh, not the chest, no.
Don't let me change your mind. I thought you were on something brilliant there.
Well, the thoracic cavity.
So what if the thoracic cavity is being interrupted by the abdominal cavity, like in a diaphragmatic tear? That's where I thought you were going. I know you're going there, Luke. I'm going to give you credit. So what Luke's trying to describe is your diaphragm can rupture and your guts can go up into the chest. And so when you're auscultating the chest, if you hear bowel sounds in the chest, y'all know what bowel sounds are, right? After you had that big T-bone steak. When you hear that up in here, it's not normal, is it? Look, your intestines or your stomach have came up into the chest.
DOA?
Not necessarily. Some people walk around with a little bit of that going on all the time called a hiatal hernia, where part of their stomach is in their chest anyway. And they live with that. No, they don't live comfortably with it, but they live with it. Yes, we're auscultating for bowel sounds, we're auscultating for lung sounds, we're auscultating for heart sounds. And we know what normal is, or you should by now. And then we can start getting into the abnormal. How else? Somebody said palpate. Palpate for what?
Tenderness, deformities,
Crepitus.
decapitalis.
Don't say that. Equal chest rise and fall. Riley, I'm going to touch you again. I come up to a trauma patient. I put both hands on the chest, which either side's accessible. And I want to feel one respiratory or two respiratory cycles to see if both sides move up and down equally. Okay, what else? What's the crepitus I spoke of? When I'm palpating a chest and I'm feeling for crepitus. What is that? Yeah, it's those bone ends rubbing together and it's like, oh, damn, don't do that. That feels like it might hurt. Yeah, and you can hear that. You can hear those bone ends grating together. I'm feeling for something called subcutaneous emphysema. We're knocking out the whole assessment part of this slide. That's awesome. We don't have to read that to each other. What is subcutaneous emphysema? Air under the skin gives me an indication of a airway rupture. Yeah, the airway is no longer intact. Remember, the lungs are part of the airway. Anything else I'm feeling for?
You feel up here or puncture bone.
Okay, I can feel up here because that air, that subacute emphysema tends to defy gravity. Air tends to float up. So depending on how they're positioned, if they're upright in a car and I've got air bubbles under the clavicles, oh boy, you're probably going to die.
Bilateral pulses as well to see if the arteries have ruptured, if they would or something.
Okay, so I can palpate pulses, and when you speak of that, you're talking about palpating bilateral pulses, or a pulse on each side, like both radial pulses at the same time? Sure. Both brachial pulses at the same time? Sure. Because as that aorta splits off into the right and left subclavian arteries, subclavicle arteries, and go out and feed the arms, if I've got an aortic tear and some of that's leaking out, one pulse may not be as strong as the other one. You can also do that with blood pressure. Blood pressure in one arm will be different than blood pressure in the other arm. Sure. Anything else I might palpate for? I'm going to throw one on the board for you because I just have to do that, don't I? Flail segment. Ding, ding. Flail segment. Okay, so there is a textbook definition. What is it, Jake?
More than one broken rib in two areas.
More than one broken rib, broken to more than one. Huh? What? What'd you say?
Causes unequal chest rise and fall.
Okay, there's the definition I want, right? I've never been on the field with a flail segment and go, I wonder if it's one or two or three ribs broken in one or two or three more places. It's one of those textbook definitions versus reality. And even then, reality is going to overrule the textbook here. Flail segment, one segment moves different, and I'm going to use DIFF, than another. One segment moves different than another.
When you say segment, you're talking about the ribcage itself?
A segment, the broken piece. There's just a piece of the chest that moves paradoxically to the rest of the chest. It just, when this goes out, the rest of the chest goes in. And then just the opposite happens. So we don't have uniform chest wall movement with a flail segment. Can you see a problem here? What happens to the tidal volume when the patient has a flail segment? Yes, it goes down. They don't have any tidal volume. When we inhale, we expand the chest wall and flatten the diaphragm, try to suck the air in, or actually the atmosphere pushes the air in. If a piece of this chest wall moves paradoxical to that, in that case it would be moving in while the chest moved out. Well, that took my vacuum. That negated my vacuum that I needed in the true airway. It may or may not cause a punctured lung. It may or may not cause a punctured lung. But it will cause no gas exchange, even though the patient's breathing probably rapidly and they're using all the inspiratory force they can, but no air is moving because this is negating that. This moving piece, this flail segment is not there. So wouldn't it make sense to you that we need to stabilize that flail segment?
Yeah, we just hold pressure.
So let's go back to 1989. I was there and I was taught, do not answer this way on a test, okay? But I was taught, let's throw some sandbags on it. If the problem is it's moving, let's not let it move anymore. So we would throw actual bags of sand. And we were like, well, that's kind of nasty because they get bloody and it's hard to clean sand. So circa 1993, we decided, let's throw bags of IV fluids on them. What's the problem with both?
You're making it harder to
You're making it hard to breathe when it got weight on my chest, and it's already hard to breathe. But the flail segment didn't move anymore. Hell, none of it moved. Then we decided, I got a better idea. Forget the bags, forget the saline. Let's sling and swath their arm to it. So let's splint their arm, and then let's swath, you know that swath that goes all the way around? Let's swath their arm against that flail segment. And that way it'll stabilize it. Once again, we're restricting what?
Breathing.
Chest wall movement. Well, it took us to about 2015, I guess, before we realized, what's the best way to splint a flail segment? Well, we gotta move the air.
Just hold me.
Breathe for you.
There you go, Frank. Splint it from the inside out. How do you splint a flail segment from the inside out? You also know that it's positive pressure ventilation. You get a back valve mask and you go, I'll get it in there for you. And that's how you do it. And then you get an ALS team there, and they will probably intubate that patient. I don't have a video of it, my bad. I probably should pull one up, but you can go to YouTube and look up flail chest segments.
Yeah.
Did she show you one? And they're horrible, aren't they? And it's like, how do you splint that from the inside out? And that's probably a person that the paramedic's going to sedate, paralyze, because they're going to need some surgery to stabilize that and put the bone ends back together. Now, at what risk? What's the risk of the flail segment? Somebody said punctured lung, collapsed lung, pneumothorax, hemothorax, outside of the lack of oxygenation and perfusion and stuff like that. So yes, I'd be palpating for a flail segment. So that's my hands and that's my ears. How else can I assess the chest, since we're on that?
Look.
Eyes? Yeah, I wouldn't want a blind man assessing my chest if I was in a trauma situation. So we need to look. And don't say decap BTLS, but what specifically, what do we look for?
Deformities. Or anything abnormal.
You want to say it so bad, aren't you? You want to say it so bad. Stairs like, I got a word, but it's on that list. Specific. Applicable specificity. What'd you say, Jonah?
You're looking for that whenever the chest goes in and it's not. The flared chest?
Okay, I can see that flail segment. Not only feel it, but I can see it. I've seen this term on the registry, or I've heard it's on the registry. Scaphoid. Another reason you guys need to read stuff. You know what scaphoid is?
Tell us.
Does anyone know what scaphoid is? You can have a scaphoid abdomen or you can have a scaphoid chest. These are visual, you interpret these visually. Let me do the abdomen first. A scaphoid abdomen, I'll give you the Oklahoma definition. It looks like you could eat a bowl of cereal out of your own belly. It's sunken in, it's caved in. So what would a scaphoid chest look like? Caved in, sunken, caved in. If I've got a scaphoid abdomen, where are the things that used to make it poke out at now? Probably up in the chest, aren't they? If I got a scaphoid chest, where are the things that are in the chest at?
Abdomen,
Or
back,
maybe in the head. Ding ding term here. Traumatic asphyxiation. Traumatic asphyxiation. This is a blow to the chest that is so severe that it shoves some of the contents, specifically the blood and the air, up into the head and the face. These people look purple.
Is it just the chest? Or
Some of it can go to the abdomen too, but when you look at them, they have bulging eyes, bulging tongue, bulging lips, dark purple bruise all over their face.
are those people doing that?
Most likely. The blow to the chest was so severe that it just pushed the blood contents up. So there's no telling what all ruptured in doing that. But that's a visualization thing. So we've got traumatic asphyxia, we've got scaphoid chest. Now I'm going to have to ask you, is a scaphoid chest convex or concave?
Okay.
Is it concave?
Yeah.
Regan, is it concave? Looks like a cave? It's caved in? Okay, that's how I remember that. I always get convex and concave messed up. What else could I see? Oh, what about this bubbly little thing that looks like there's a hole in it and it's bubbling? There's a term for that. It's called a sucking chest wound. So I'm going to look for a sucking chest wound. So here's another ding ding. There's a lot of test questions here in the first 20 minutes of class. When I see sucking chest wounds in a test question, when I see sucking chest wounds in real life, what should I think of immediately? Seal it, right? Seal it. Now I'm hearing 3-sided, I'm hearing make sure they're ventilated. All that stuff is applicable, but your first immediate response is seal it. With what? Gloved hand. Gloved hand is faster than any occlusive dressing you can go get out of your kit. Just put a gloved hand on it, call for an occlusive dressing. What is an occlusive dressing?
3-sided something.
Doesn't let it air.
Dry.
Yeah, it's an airtight dressing. Saran wrap, aluminum foil would fit that category, but it's not preferred. Vaseline impregnated gauze or petroleum jelly inside a gauze pad is also occlusive, or your gloved hand. Now, does your textbook still talk about 3-sided dressings? Let's look.
Yeah, it does.
What page then, Smarty?
1,233.
1,000. It's not that far back. You were close. You're about 100 pages off. You're about 100 pages off. Okay, sucking chest wounds. A commercial occlusive dressing may be used to seal all 4 sides of a chest wound, such as an Asherman chest seal. So they want that flutter valve effect. An occlusive dressing without a flutter valve may be taped to the patient on 3 sides of the dressing, allowing air to leak from the 4th side. Bullshit. That's hard to do. You got a bloody trauma patient, tape doesn't really stick too well to them. Second of all, occlusive dressings, especially the Vaseline gauze, you're not going to get any tape to stick to it. If you got saran wrap looking dressing with tape, well, you know what that's going to look like to you by the time you get done with it? You're going to be all tied up. I can't even wrap a Christmas package under the influence of wine and a nice warm fire, everything calm and cool. And I get out on a trauma scene in the middle of the night in a bar fight. It's going to be real hard for me to tear tape, put the saran wrap down, and make sure it's all 3-sided. If I do manage to pull off that feat of Christmas wrapping, that blood and stuff starts to dry and it's sticky in itself, and that 4th side tends to just go ahead and seal off anyway. It all sounds good in theory. It doesn't work real well. What you want to do once you seal the wound is be on alert for something called a tension pneumothorax. Ding ding, another key term today. When you seal an open chest wound with an occlusive dressing, your next problem is created by you. In other words, if that air doesn't escape, it can start building up in the chest cavity, creating what's known as a tension pneumothorax. So you have to be alert for that. Once you seal it, now you're on alert for, is the patient going to worsen? And we'll talk about what that looks like here in a little bit. But I'm just telling you, as soon as you see it, you pause, you seal, and then you move forward with your assessment. Is there anything else we can see? Impaled objects, bruising,
Obvious signs of death.
decap BTLS, all, yeah, obvious signs of death.
Could you
Um,
see what the bubbles?
Sub-Q emphysema, yeah, it's a possibility. Probably not, but it's a possibility. That's the one you'll feel of it, and it'll just feel weird. But you maybe could see it.
And where would that be? Would that only be?
It's going to be positional dependent, meaning the air is going to tend to rise.
Okay.
So if they're sitting upright, trapped in a car, it's going to be in the clavicular area. If they're lying flat on their back, been there a while, it could just be on the surface, because the air is going to migrate, because it's the lightest, lighter than the blood. Piece of trivia that's very important. A fracture of the first rib is usually fatal. Rib number 1, which if I ask you to touch your rib number 1, you wouldn't want to. It would hurt to get to it. It's going to be deep under the clavicle, or it's going to be deep over the top. If you press behind your clavicle right here in that void, that triangular shaped hole right back there, when you touch that, does it kind of hurt? If you press it a little hard, it kind of hurts. It's because you're touching what's known as the apex of the lung. APEX, the apex of the lung. Down here's the base of the lung. That's why it kind of hurts. So under that clavicle, under that tissue, down in there is rib number 1. Imagine the force it takes to break rib number 1. Well, the first thing it's got to do is go through the clavicle, then the tissue, and there's got to be enough energy remaining to go ahead and bust the first rib. What type of trauma are we talking about? What type of energy transfer? A lot. And so when we get that deep, we've got a lot of energy to some very vital organs right in the base of the neck and stuff. That's why it's usually fatal. A blow that hard is usually fatal. Now, a clavicle is the most commonly fractured bone. But going all the way to the first rib, you'd have to go through the clavicle to get there. So Gus, to your question, where's that sub-Q emphysema going to be? Well, if the tip of the lung is right there, the apex of the lung, that's probably a good place for it to leak out. So if we get knife wounds and stabbings and somebody's coming over the top like women do, women using a knife swing like this and they come down, then go right into that area of the neck. The neck is so close to the thorax, when we talk chest trauma, we've got to also talk neck trauma, or vice versa. And when we get down to abdominal trauma, we've got to talk chest trauma because it's connected to it. Does that make sense? So don't let them get out of hand. So we've listened to it, we've felt it, we've looked at it. I don't think we need to smell it, do you? Unless there's some, I don't know. I doubt infection or gangrene set up yet, so I don't have to use the sense of smell. I don't have to use the sense of taste, I hope. We only use the sense of taste in checking diabetic urine for sweetness. That's what they did before they had glucometers. To see if you were when you were if your physician or your healthcare provider back in the day thought you had diabetes, they would dip their finger in your urine and taste it, and if it was sweet, you were a diabetic.
Can't you do that yourself?
Can't you do that yourself? There are people who drink their morning urine. There is a subculture of our population who think that's good for you. And the morning urine is the best because it's most concentrated.
With more toxins.
There aren't any toxins in urine. Urine is sterile unless you have a UTI.
It's pure. You ever seen a
The only problem with drinking your urine in a thirst environment is you're getting the electrolytes recycled and you're just getting a buildup of salt with not enough fluid.
I was told you can do it once.
Yeah, once or twice is about it.
Just once and only once.
Once and only once. That's probably all you would want.
Yeah.
Once and only once. No, there actually is. Now, I know you're a sheltered kid. You told me that. But there is a segment of the population who will drink their morning urine. Some of the, wasn't it some of the Roman gods or the rulers in Rome and stuff? They were well known for it, I think.
Right, there's a pea gun.
Well, give them strength and virility, and so they believed. I'm not in that subculture, I'll tell you, okay? You're glad? Well, what's it to you? No, not in that
You're
culture.
so close to us every morning. I don't want to smell
Yeah, it's like, no, So we've done a pretty good chest assessment now, I think. So let's get into specific conditions and why they kill us. We don't have to go through this anymore, do we? Or do we? I don't think it would hurt anything, but just kind of visualize where we're talking here today. The diaphragm flattens during inhalation. As a review, where does the diaphragm get its nerve supply? Where does it get its innervation? What part of the spine?
In the neck.
In the next part of the spine called the cervical. C3, C4, C5. So which spinal nerves innervate the diaphragm? C3, C4, C5. And if you want to remember that, say C3, C4, C5 to stay alive. And that's what runs the diaphragm and the intercostal muscles. And then when we talked about spinal cord injuries yesterday, that's why people end up on ventilators when they disrupt that portion of their neck. So the diaphragm flattens, the intercostal muscles or the rib meat contracts, and when it contracts, it's built in such a way that it makes the chest wall get bigger. That's called a bellows effect. Do y'all know what bellows are?
A big bag.
Okay, a bag,
Pushes air.
like an accordion. Do y'all know what an accordion is? What moves the air through the accordion?
You.
Bellows. If you watch The Night Before Christmas and on the fireplace, there's this bag that they pump and it's blowing air to get the fire going. What's that called? Those are called bellows. So what's a bellow effect? Well, every time you inhale, you're having a bellows effect, aren't you? You're expanding, creating negative pressure. How much negative pressure? About 1 torr. 1 torr, which is the same as a millimeter of mercury. T-O-R-R. Now, you are intelligent emergency medical technicians, and you went to the best EMT school money can buy. So you should know what a torr is. A torr is a millimeter of mercury. It's a unit of measure for pressure. A torr is enough energy to raise a millimeter of mercury 1 millimeter in a column, like a barometer. Baro pressure meter measure. 1 torr. That's not very much, but it's enough that nature hates a vacuum. So if I got a negative torr of 1 and the atmospheric pressure is 768 torr, and I create a 767 torr inside my chest cavity, what's the air going to do? Rush in and fill it. Equalize the pressures. 1 torr. Not very much. That's 1 small beep on your blood pressure cuff. How much chest trauma can you stand to negate that? Not very much. So when we come in with positive pressure, we create more torr than what's in the chest, therefore the air goes in there. Make sense? Is it possible that I can create so much torr, so much pressure in the chest that blood can't get back to the chest? Doesn't blood have to come to the chest in order to be pumped out by the heart? Don't I have to have a return of blood through the vena cava? Yes. So if the chest injury itself creates pressure in the chest, called a tension pneumothorax, is that increasing the torr or the pressure in the chest to the point where blood will not return? So people with a tension pneumothorax will also have a really low cardiac output, won't they? And I'll know it's backing up because what will happen to the jugular veins now? Yeah, they start to swell out or distend. And that tells me that the pressure in the chest is higher than the pressure in the neck. There's a lot of physics in medicine, a lot of electrophysiology, a lot of chemistry, a lot of biology. Medicine wraps it all up, a lot of mathematics. So blood can't get back, and so it starts backing up into other areas. This is why we don't overly ventilate in CPR. Because in CPR, we're pressing on the chest. We're also ventilating, and if we overventilate in a CPR environment, we keep blood away from the heart, and that's not what we want to do. There are some EMS agencies who do not do ventilations during CPR for that reason. And if I'm pressing on the chest at least 100 to 120 times a minute, am I creating a bellows effect? So I'm moving air anyway. There's just some old lady sitting on the American Heart Association committee going, you gotta breathe to live, and we can't do without it. And they're like, give her her due, give her 2 breaths every 30 times. I mean, come on. I mean, it used to be 15 to 2, right? So we're winning. Us chest compressors are winning, but there's somebody who still wants the 2 breaths. And it's really sad because how many people will not do bystander CPR because they think they have to do mouth to mouth? A lot. So it's kind of sad, isn't it? A&P, ding ding, neurovascular bundle lies closely along the lowest margin of each rib. Now, the only reason you need to know that as an EMT is because when the paramedic goes to stick the needle in, you can make sure he or she puts it in the right spot. You can check them. When we use a needle to decompress or let the air out of the thoracic cavity, when I take a 14 gauge IV needle and I press it in the chest, I'm going to put it on top of the rib. If these are my ribs, I'm going to go over the top, not underneath it, but over the top of it. Why not underneath? I will lacerate the neurovascular bundle. There's a nerve, an artery, and a vein under each rib. And if you go eat some barbecue ribs later today and you analyze them really close, you can see that neurovascular bundle. And we don't want to puncture that with the needle. Each rib has that. Second A&P, ding ding. The inside wall of that thoracic cavity is lined with a membrane called the pleura. The pleura. That pleura comes down the comes down the chest wall, gets to the bottom, gets to the diaphragm, turns back up, and now it touches the lung. The chest wall and the lung both have a pleura lining. In between that lining is a potential space, meaning it's really not a space, but it can be one. But there's a lubricating fluid between the chest wall and the lung that allows it to move like this. That is called pleural fluid. Pleural fluid. It also creates a seal, so when the chest wall moves out, what follows along with it due to the surface tension of it? The lung. So that's why the lung follows the chest wall. And it's also allowed to slip. If there's a puncture, sucking chest wound, or a puncture in the lung, and air starts to get in that space, the lung moves out, and the chest wall moves out and the lung may not go with it. Another example would be if you take a wet glass on a nice table in condensation, and you go to pick the glass up and it's like stuck. All right, but if you break that seal, it'll come apart. So two pieces of wet glass together are stuck together. You can get them apart by blowing air in it. You ever had stacked plastic cans or trash cans or cups or something, you blow air into them so they'll come apart? Sometimes I think I'm talking to myself. Y'all nod or shake your head like I don't know. That's the physiology of how the lung is stuck to the chest wall, and we want to keep that in place. Now, let's go medical just for a minute because we're here. If you get an infection in that lining and the two pieces stick together or rub together, that's called pleurisy. Some of you may have had pleurisy before if you got a little infection going on there. Very, very painful to breathe. You don't want to breathe because it hurts so bad. And when you listen to that, it sounds like two leather gloves rubbing together as the chest wall moves. And that's the pleural lining rubbing across itself. But in trauma, we're more worried about it getting too far apart or getting air in that pleura space. That's why the paramedic sticking the needle in the chest is to get that air out of that space where it doesn't belong, okay? So there's two linings to that pleura, the one that touches the chest, the one that touches the lung. I would expect you to know there's that word visceral again. Visceral is deep, it's inside. Parietal is the outer lining. So the one that touches the chest wall is the parietal, the one that touches the lung is the visceral portion of it. I have an Oklahoma way of to urine again. We pee outside our body. The pee is on the outside. We pee outside the body. But visceral is that deep core feeling or that deep lining of the pleura. We want this to stay intact. We want that to stay intact. Another key word coming up, mediastinum. Mediastinum. What's media mean? Middle? Mediastinum, middle of the chest. So there's a region of the chest or an area of the chest called the mediastinum. And by definition, it houses the heart and the great vessels. The mediastinum is in the center of the chest and it houses the heart and the great vessels. Would it stand to reason that a mediastinal injury would be significant? Anything that injures the heart or the great vessels? I don't know why girls laugh when they come out of the bathroom, but they do. It was almost sounded distressful at first. The heart and the great vessels.
Wait, mediastinum houses the what?
Heart and great vessels. Great vessels being the vena cava and the aorta. Luke, tension pneumothorax. Let's just say it's happening on the left side. Air is building up in the pleura space. And it's building up and it's building up and it's building up. It's putting pressure and pressure and pressure. Would you expect at some point that it starts pushing the mediastinum away from itself? So if I'm building pressure here on the left side of my chest, would it make sense that the mediastinum is pushing over? If the mediastinum pushes, or what we call mediastinal shift, if it shifts to one side or the other, what happens to the vena cava and the aorta as it shifts? They get kinked, don't they? It's kind of like a water hose getting kinked. What happens to the trachea? Well, maybe, but it will certainly start moving over. So while we're talking about chest, and I'm assessing the chest, I also have to assess the neck at the same time because I'm looking for tracheal shifting. Tracheal shifting. The trachea should be right in the middle of the neck. If it starts shifting, pulling to one side or the other, the tension pneumothorax is on the opposite side.
Did you get JVD too?
Oh, absolutely, because of the kink. So once again, I assess the neck, JVD, tracheal tugging, tracheal shifting. Now I have mediastinal shift. That should indicate a tension pneumothorax.
How would you tell in an obese patient?
Well, that's just one of the disadvantages of being that, because it makes my assessment that much harder.
Just listen to lung sounds, right?
Yeah, and sometimes that's hard to do because the more obesity, the more adipose tissue on top of it's harder to hear through it. But yeah, so I'm going to take this relatively thin guy here who's in pretty good shape. An assessment technique called percussion. Well, they can't see it. I'll use this relatively thin guy. Percussion. So as I percuss the back, it sounds hollow, right? I get over the spine, it sounds pretty solid. Then it goes back to a hollow sound. If I percuss that and it's like super hollow, like a drum, then it's filled with more air than it should be filled with. Another thing you can do is put the stethoscope up to the chest wall and ask the patient to say 99, 99. If you hear 99 very distinctly, they're full of fluid. If you hardly can hear 99, it's full of air, because fluid will transmit sound better than air will. You ever been at the lake swimming? You go underwater and you hear a boat and you pop up because you think it's about to run over and you don't even see a boat because the lake water transmitted the sound so effectively to your ears. So that's called percussion. When I tap something, it's called percussion. It's like you would a watermelon. And when you get that really ripe watermelon sound, it's probably full of air. Okay? Noisy environment, it's going to be tough. Obese patients, it's going to be tough. But it's something you can do. Once you get the environment controlled, you can listen to it.
Will you always see that shift?
It's a late sign. So that's going to be my next point. Tracheal shifting, mediastinal shift is a late sign. It's kind of like blood pressure. I don't wait to see it. I'll do something like this long before, or I'll just listen to lung sounds. And if they're diminished, we're set up for this to happen. If you see it upon seeing, it's been there a while. And it's a late sign, and it's a dire sign because there's no cardiac output. And it needs to be decompressed relatively quick.
Is the tracheal shift only caused by tension pneumothorax?
That's a great question. I hate your question because it says only or always. Mostly. Yeah, let's go mostly. There probably are medical conditions that would cause tracheal shifting. Tumor growth, carcinomas, things like that.
But in a trauma setting?
In a trauma setting, yes. In a trauma setting, yes. I can't not say this, even though it's going to revert to medical for just a minute, okay? Please understand this. You can have a tension pneumothorax in a non-trauma patient. You should know this term. If you don't, well, it's never too late. There's a term called a bleb. Have you heard that before? I can't recall telling you this one, but maybe I have. A bleb. A bleb is a weakened area. Specifically today, we're talking about a weakened area of the lung. So let's just take an old COPD patient, okay? Somebody's got COPD, they got diseased lungs, and they're just sitting there watching Price is Right, and they rupture a bleb. Well, a bleb is a weak area of the lung, and it ruptures. Well, air now can escape from the lung into the pleural space. Mostly in trauma, we talk about it coming from outside in, but it can happen from inside. And that's that little old guy with the diseased, weakened lung, and a bleb ruptures. Now air starts getting trapped in the pleural space. Can that progress to the point where we have a tension pneumothorax, tracheal shifting? Absolutely. So maybe that builds on your question a little bit.
Is the bleb, is that only for the lung, or can it mean like weakened?
It can mean weakened anything, but in medicine we usually, when you hear bleb, you think lung.
Okay.
My water hose had a bleb this morning, I noticed. I'm still watering grass, and it's like, give up already. It's almost November. I'm like, I know, but if we live in the Sahara now, and it's never going to rain again. You know our next rain will be a flood, right? Yeah. Well, this spring, you better get your boots because it's going to flood. It's the way it is in Texas and Oklahoma. So back to your point, we can get a tension pneumothorax in a non-trauma patient. If I can tell you a story, I'll give you a break and show you how easy this can sneak up on you. I don't tell you the stories without intent of learning, okay? So please understand that. When I worked at the department, there was some of those guys who didn't ride the ambulance, even though they had EMT and paramedic, and they were on the truck, they had seniority, they never made ambulance calls. And if you were a new guy, for 7 years, I never got off the ambulance. So if there's an ambulance call, I went on it. And one day I had a new driver, new to me, but he'd been there like 30 years. He was an old crotchety old guy. All he would do is sit in the recliner and smoke cigarettes all day. And he was my EMT that day. Great. I'm pretty much by myself. Other than the fact he knew every address in the town. Like better than he knew his name. You could give him an address and he could tell you exactly where it's at and drive right to it. He had the map in his head, I promise. Even down to the location of fire plugs. That was his gift. And there were times we'd walk out there and go, hey Ronnie, where we go? You're going to turn here. And where he'd come out and say, hey, you're going to the 300 block of Morton Street. You realize that it skips the 400 block, right? And you're going to have to make the UE to get to it. And you're like, oh, great, thanks. He said, no, that did in the cul-de-sac down there. You can't do that. And you're like, this man is gifted. He has a value, right? But it's not as my EMT partner. I'll just be honest with you. He could get me there, and he could get me to the hospital. But other than that, I'm pretty much on my own. So in the middle of a cold night, we walk in, and as soon as you open the door of the house, there's the man sitting in the recliner in obvious respiratory distress. Can you describe what position he was probably in? Tripod. Can you, if I told you he had COPD, could you tell me what he looked like? Barrel chested, thin, puffing, up on his knees. Help. I mean, it's bad tonight. It's bad tonight. It's a cold night, the weather, and it's like, yeah, I mean, it happens. You get a lot of breathing difficulties when the weather's like that. And so I kneel down in front of him, and I take my stethoscope, and I'm listening to lung sounds. Is that okay? Is that an appropriate assessment at this time? If I establish he has an airway? He's got an airway. He's speaking in one-word sentences. He's breathing, and he has a pulse. I'm in my secondary survey now. But it's focused on what? His respiratory system. So I take my stethoscope out and I go 1, 2. And that's what you should do when you're examining a chest trauma patient or a respiratory patient. Stethoscope 1, 2. That assessment's somewhere between my primary and my detailed. Let me see if I have lung sounds. I had diminished lung sounds. I can't remember if it's left or right, but I had diminished lung sounds. So if you heard diminished lung sounds, or let me say that you didn't hear lung sounds on one side, what would your acuity be? You'd be like, it's time to go, right? You'd be like, it's time to go. Now remember, I worked under a very restrictive protocol. I could not do needle decompression in my protocol. If I did it, I had to call and get an order for it. So it wasn't like I pulled the needle out of my bag and stuck it in his chest. I just didn't have that authority yet. And so about the time, here comes Ronnie in the cot. Bless his heart. And he's at the door with the cot. And I said, we need to go, Ronnie. He's lost a lung. That's jargon, but that's Ronnie jargon. If I said anything medical, I don't think he would have picked up on it. I said, we need to go, Ronnie. He's lost a lung. I'm pretty much like, this guy's about to crash and he needs a chest decompression quick and I can't do it, so we need to go, Ronnie. He's lost a lung. He's like, okay. Dude, you're spastic all the time. I need you spastic now. So I said, get the cot in here. This guy can't walk. So we get him over the cot, we get him in the ambulance, and he's just kind of, Ronnie, we need to go. We're going to go. Yeah, TMC? Yeah, we'll go. Okay, yeah, sure. Well, I'm going. So I'm in there, get on the phone. I call the ER, and I talk to Dr. Nance. I don't know if Dr. Nance is still alive or not, but he was my favorite ER doc. Dr. Nance was a retired ER director from Baylor, Dallas, who was had retired and come up here to TMC, just a little extra money, something to do, got bored with life kind of thing. Other than cook lobster at his lake house, this is what Dr. Nance did. Excellent physician. So glad. I said, I need to speak to the physician on call. And they're like, Dr. Nance is here? Great, because you can talk to him. So Dr. Nance, this is Brandon. I'm on the ambulance. I got a guy here, COPD patient. Believe he's got a collapsed lung on the right side. I said, do you give me permission for a needle decompression? And I'm like, this guy needs it, but I hope he don't give me permission for it because I haven't done this, but I know he needs it. And he's like, where are you? And I said, Ronnie, where are we at? And he said, we're about 2 blocks away. And then Dr. Nance could hear him on the phone. He's like, if you're that close, just meet me in X-ray. Just take the patient straight to X-ray and I'll meet you in there. And so we go, get out, we go to X-ray. Dr. Nance is waiting there and he's got the needle. And I'm like, you wasn't gonna let me do that? And he's like, if you were any further away, I would have. He said, but I'd rather do it here, wouldn't you? And I'm like, absolutely. And so he listened, he's like, you're correct. Let the air out. The guy had a bleb. I go back. They've got the guy now in X-ray, shooting X-rays of him. I come back out to finish up, clean up my paperwork. Ronnie goes, what was all the fuss about? I said, Ronnie, the guy had a tension pneumothorax. He said, what's that? And I said, I told you, he lost a lung. His lung had collapsed. He said, well, I wish you'd have told me. I'd have picked it up a little bit. Almighty. I didn't want to cause trust in me, Ronnie. But back to your point, it doesn't have to be trauma. It doesn't have to be trauma. It can be lung cancer. It can be COPD. It can be just a big, tall, lanky dude that drags his hands when he walks. You know what I'm talking about? That Michael Phelps looking guy or girl. They got really long lungs. They're built to swim, aren't they? Or jump in basketball. When those people go, ow, I can't breathe. What's happened? They got a bleb. Their lungs are so long that they're thin. So you think it's an athletic advantage to be built like that, but it's actually a physiological disadvantage because you got weakened area of the lungs. So those big, tall, long, lanky kind of guys, athletes, they get blebs. And when they rupture, they can create a tension pneumothorax too. Yes, Billy?
What happens when they get spontaneous pneumothorax?
That's it.
Oh, okay.
That's it.
It's just.
So a spontaneous pneumothorax is going to be one caused instantly or by trauma, and then the COPD would be just...
Spontaneous pneumothorax, COPD, bleb in the long, lanky guy. If you get a ruptured lung due to trauma, then it's not spontaneous.
Yeah.
Spontaneous means without traumatic cause.
Yeah. Okay.
We had a 16-year-old girl who, almost all the pneumos I've seen, they're either unconscious or they're in a lot of pain.
Mm-hmm.
The 16-year-old girl got in a wreck on her jet ski. She's going like 50. So thank God I activated her as a trauma. But anyways, so we get her back there and she's like not in any pain. She said she's having a little discomfort and it wouldn't go away. So she decided to come in. She ended up having a huge on her side.
But nothing external.
She was fine.
Yeah, just the blow was so significant that it tore the lung from the inside. Looks like a spontaneous, but there was a traumatic cause to it. Yeah, you have to do a good assessment.
That's what it was while she was walking around.
So,
Not
but
any pain.
yeah, like my guy who ran 2 miles after running his Jeep up a tree. But the mechanism of injury said we need to really focus. It's like you walk up on somebody and they look okay, but you look at what happened, you're like, you should be dead. But you're not. Okay, it's a miracle. You lived. And you better start looking because they got a hidden injury. And when we come back from break, we will talk about come on. It's all the assessment. This thing's slow, remote slow. Right here. That's our slide when we come back. The deadly dozen.